team, if we do have access at that point of time at night, that would be the best possible solution to attempt to embolize the gastroduodenal artery and control the bleeding. But I will have to consider that either this option is not there or it fails, then to take the patient up the theater for
So you
re-laparotomy.
have an option of interventional radiologist, and he tried to occlude the GDA, but while he attempting, he says that you are in the IR suit as well, and while he was attempting, the GDA stumps is so small, it was flush ligated, that he cannot actually go to the GDA stump and selectively embolize the GDA. What are the options next?
One option is to consider taking the patient to theater for laparotomy and to try and control the bleeding during laparotomy with sutures. If less likely option would be whether to embolize.
Is there any option of stenting the hepatic artery at the ostium of the GDA?
Yes, there is, but again, with it flush ligated and bleeding from the, yes, I think that it should be an option to consider stenting if the radiologist feels that is possible, then yes.
Okay, if somehow the radiologist is not comfortable and you decide to take him to the theater, how you are going to explore this area, and what are the potential challenges? How would you prepare this patient?
So preparation of the patient.
This is the last question. Sorry, this is the last question. Take your time. Okay.
Preparation of the patient will be crucial to continue resuscitation. The anesthetic team will obviously have to be involved urgently to continue stabilizing the patient. I will brief the team that we are dealing with the potentially pancreatic hemorrhage from the gastroduodenal artery, which is potentially a fatal complication if we're not able to control it. We'll need maximum support from the hematology in terms of blood products as well. And in theater, of course, after the surgical checklist and preparation, will go through the same incision, go in and clear all the blood clots that are there, and try to find the area of bleeding, which I know is now from the CT angio is going to be the gastroduodenal. So I will just look straight at that area first, see if I can control it with first pressure, and then try and put sutures over there, which hopefully without compromising the hepatic artery.
Right. So that's great.
Extremely.
That's it. Finish.
Is it audible?
Yes.
Yes.
My side is finished. Now up to you guys.
More than I don't think these scenarios will be discussed as a short case or long case. These will be like a Viva
yeah.
case. Someone, I think Mohammed, can you please mute, or I have to remove you? Sorry, I think it was extensive.
So before people comment on it, the reason why I made this scenario of 2 or 3 things: intraoperative bleeding, I heard, and while I was doing preparation, I found that in each specialty it can come on any given day. For colorectal, it can be a presacral bleeding near the zone 1. For the HPB, like the scenario I gave, so I just manipulated my scenario into the HPB. So there are different techniques are written that are mentioned in it. And the anatomy, I just said that because this was a question was asked from me by one of my consultant, what is the anatomy of middle colic vein? So I just put that in as well. And the third thing is that what are the interventional radiology options? These are always a question which can come in any discipline. So that's how I made this scenario.
No, that was really good, very helpful. What are the tributaries of middle colic vein? I'm still struggling with that.
Middle colic vein?
Yeah, like what goes into the middle colic vein?
So there are 3. There's a trunk is known as the Helle trunk. I don't know what is that called. Trunk of Helle. So there are actually there are 3 veins, right? Gastroepiploic vein, then one from the pancreatic vein, and a third from the right colic vein. They all combine and make gastrocolic pancreatic trunk of Henle.
Right.
And that
Okay, yeah.
drains into the middle colic vein, which is coming from transverse colon, and then they join and then into the SMV.
Yeah. Okay.
Is it a standard or is there any variation there?
There is a lot of variations. Yeah, there are hundreds of variations.
I don't think anything in that area is always standard. Anything in that area you can expect any.
There are hundreds of variations.
Yeah. Okay, shall we go ahead? Who wants to take up the scenario?
I am happy.
Anything else? Any other comments?
Prashant, let's take the comments at least from Prashant.
Oh, Prashant was not there in the scenario, and I was not in the scenario. But anyone who wants to comment, I can. I was not there. Sorry, guys. I was absolutely out of. We both were discussing something on the out of the screen.
No, it was not. It may come in your scenario, Varun. So it's a very common scenario that I gave.
I know.
Intra-bleed.
Yeah, I was discussing with Varun with regards to something. So we missed this, but I think Saqib, this is what this was a good scenario, and one scenario in the exam would be something which is extremely difficult, and I don't know how the marking on that scenario is done. And anatomy, they can ask you anything about anatomy, and this was a valid question about the variations and what is the anatomy of the gastrocolic trunk, and they will also encroach on not just surgical options, which you rightly said. So any other interventional options, and what interventional options, and suppose there is no a radiologist available, how are you going to interpret this? So one of the scenarios would be difficult, and I think this would classify as one of those scenarios.
Cool. And the answer for that gastroduodenal artery, gastroduodenal first and then right gastric, right?
Yes. So Senthil, I have divided, if I am doing a laparoscopic approach and the bleeding comes in, so I have divided. I mean, I have made some of algorithm by just reading the books and reading the text, which is that I will inform the anesthetist that we have encountered the bleed. More importantly, I will inform my scrub nurse that we have anticipated bleed. Please, can you prepare this stuff and open for an open operation, which we may require.
Okay, stop there. Any laparoscopic procedure in NHS, always the nurses are ready for open laparotomy. There's nothing called as laparoscopy alone. It is always the laparotomy tray will be ready side by side.
Yeah, but to let them know that we are planning for an operation, so they can do the necessary things, right? Maybe the retractor you may require, or maybe some form of support. So you have to inform your team that we may need to operate. The second thing you do was very good, that the pressure. But other than the pressure, the two other laparoscopic approach that's are written in the cracking as well are one is that to put sutures that you rightly said, and also use of some hemostatic agents like Surgicel, Fibrillar, if you can place them.
Yeah.
And then the third thing is suction, you have already mentioned. So you have mentioned two of them, suction and suture, but the hemostatic agent can be added as well. The third thing is that when the patient became unstable, you did the laparotomy, you required a laparotomy, you wanted to have you wanted a help of a senior colleague, that was fine, which is written in the book as well. Vascular surgeon can also be asked for help as well. That is the one point which was missing. And then once the bleeding was 800 mils, so although it is an anesthetist job, but you can still say it's written that you will activate the massive transfusion protocol, because this patient will need a massive hemorrhage protocol requirement.
At 800 mils, is it? Sorry? I mean, is at 800 mils blood loss?
Or 400, you can say, you can say at 400 as well, whatever you want to say. But 800, it's become almost mandatory, because 800 is quite much now. At 400, yes, you can wait and watch. The rest of the things were fine. I think laparotomy was required. Patient became stable. You did resection. Post-op bleeding, most common cause, you correctly identified GDA stump.
As Senthil is right. I think at 800 mils, I don't think you have to activate massive transfusion protocol, because it doesn't fit into the massive perfusion protocol criteria, like in any way. Not
so
the
massive hemorrhage, Varun, is not only explained on the amount of output that, I mean, I agree with your definition that it needs to be 24 hours full replacement, 3 hours half replacement, but it is also amount of the blood per hour you are losing. So,
like you mean like per hour it is crossing 150 mils?
Yeah. So in one operation you have attempted 400 mils, and then you are losing in next few minutes to up to 800. What else you require to go for a massive hemorrhage protocol? Huh? So it's a big good rate with which the patient is dealing, and that's the reason why I gave the two different figures, 400 to 800, just to tell how much in a speed he is losing the blood. But rest of the fine. But yes, hepatic artery occlusion is one of the option, or hepatic artery stenting is one of the options.
Shakib, the venous tributaries, just double check once, because as far as I know, most of those drain directly into superior mesenteric vein unless it's a variation.
Agree. Middle colic vein directly takes the blood from the transverse colon, runs in the transverse colon mesentery, and drains into the superior mesenteric vein. But it have a one on the left, it can have a tributary that is draining, which is called a gastrocolic trunk of Henle, which is an extra vein that is coming and joining.
But again, that will be a variation, because otherwise it normally drains into the SMV.
That I agree. I agree 100%. That's the reason why.
When you asked the question, I went totally blank. I'm like,
no, I agree. And the GDA is generally the first branch, and the right gastric.
And then right gastric. Yeah.
Okay, so Varun, you have a scenario, I guess.
You. No, I think Senthil, Sakib is right to some extent, because if you remember during ripples, we have to disconnect the gastroepiploic of the middle colic. And sometimes we may have to sacrifice the middle colic also to get into the SMV just before we do the test. So, although I agree that there might be variations, but the loop of
the trunk is between the epiploic and the middle colic going into the SMV.
So sometimes it will, if this is the middle colic, this will be the trunk going into the middle colic, and the middle colic will go into the SMV. Sometimes you'll find them even separate, but I think 80% of the Whipples that I have done, it goes into the middle colic, and then then the middle colic goes into the SMV. Yeah.
Cool.
Shall we go to the next scenario?
Yes, please.
Want to take it, Sakib?
I can take.
Okay. It's going to be half an hour session. It's not going to be like it's going to be like 30-minute session, 5 minutes each, jumping from one scenario to other scenario. Your scenario starts here. 25-year-old female who came in with a history of discharge from the perianal region for the past 3 days. How are you going to approach this patient?
55-year-old female came with the discharge from the perianal for 3 days. Right. So, and this is a clinic presentation or emergency presentation?
In A&E.
Okay. So, given the fact that this patient has a short history, and patient has presented in an A&E, I would first be worried for the patient hemodynamic status.
Patient is fit and healthy.
Okay, patient is fit and healthy. I will, in the A&E generally, and I will take the focus history about this discharge, how much the discharge is.
Discharge from the perianal region.
It's a purulent discharge.
Yeah.
Okay. So duration of the history, whether the discharge is associated with the pain or not.
Duration is 3 days.
Okay. Duration of the history, onset of the symptoms, whether it's progressively worsening the symptoms. Then how?
This is the has got this thing. So you got the history. You got the. What will you do in the examination?
So in the examination, my examination will, as the patient is presented in A&E, it will start from the seeing the hemodynamic status of the patient. I will do the abdominal examination of this patient. to find out any abdominal pathology. On my examination, any signs of ascites. Then I will do a digital rectal examination in which I will first do inspection of the perineum. I will see any obvious fissure. I would see any obvious swelling or perianal abscess. I would see any obvious skin tags there or not. Any prolapsing hemorrhoids or an element of a prolapse rectum.
Discharge the 3 o'clock position without any signs of inflammation.
Discharge is at 3 o'clock. So I will see for an external fistulous openings or not, whether the patient has external fistulous opening or not. And then on inspection.
Yeah. This patient has got a small discharging sinus, discharge from the 3 o'clock position.
At 3 o'clock position. So given this fact that as patient has a perianal discharge for 3 days, it looks like to me an incisional sepsis, which is now exhibiting as a discharging fistula. So my working diagnosis would be, of course, a perianal fistula. However, as the patient is presented in an A&E, this might be an underlying abscess as well. So I need to do I will complete my perineal examination. I would also do a digital rectal examination, and if this is a straightforward fistula, then this patient I will send her home probably with an outpatient follow-up for the EUA.
This patient gives a history of family history of Crohn's disease. How will you do it? What will you do it now?
So this patient, as I already planned, that this patient require an examination and anesthesia. My plan would be same. This fistula can be of either a complex fistula secondary to the disease like Crohn's, or it could be a simple anal fistula secondary to the anorectal sepsis. So I would make sure that this patient have an examination under anesthesia and also MRI rectum as well. EUA will give me a chance to do a biopsy as well from site.
This patient comes to the clinic after you gave the antibiotic, you sent the patient home. This patient comes to clinic after 2 months, and the patient still says the fistula has not settled.
Okay, so I know as a patient has a strong family history of Crohn's disease, and I know that around 10% of the patients in Crohn's can present with the perineal sepsis. So still I will go for I will request a colonoscopy for this patient. I would also request an MRI small bowel, and this patient in EUA will require the proper EUA with the placement of a draining ceton by using an Ethiborn 1, and I will put this patient into IBD MDT meeting.
Okay, you put the patient. Okay, the next scenario, 5 minutes is up. The second scenario is you are in a clinic and you have been referred by a GP with a patient with 75 years old male with dysphagia. How are you going to approach?
So I will take the focused history of the dysphagia. I would I will find the grade of dysphagia, whether the dysphagia is to the solid mucus or not. I will take the history, constitutional symptoms as well. I would take the history of systemic, his systems includes shortness of breath, bony pain, any history of jaundice. I would take the history of previous gastric ulcer disease, previous history of endoscopy, any family history of cancers, and then I will do the focus examination, which includes the assessment of his performance status.
You did all the examination, you did all the history, you did everything. How are you going to investigate this patient?
So this is a 75-year-old male. I would be worried for this patient may not having a malignant growth. So that's the reason why I will book him for upper GI endoscopy and biopsy for this patient. And based on endoscopic findings, I will plan my next investigation, which should be in the form.
So the endoscopy is normal, but this patient has got a tortuous esophagus. The report says tortuous dilated esophagus. I had some difficulty in pausing the scope at the OGJ junction. What will you think in your mind?
Okay, tortuous dilated esophagus. This patient could have an eclasia, or this patient, based on the normal findings, or this patient can have some intramural esophageal pathology in terms of a leiomyoma or GIST. I would discuss this patient in upper GI MDT meeting, and this patient will benefit with the manometry. And based on the manometry findings, I need to.
Do you want to do this? Do you want to do a manometry for this patient?
Yes, if the upper GI endoscopy is normal and and I have found that dilated esophagus, I would go for a manometry.
Okay, so you do a manometry and the patient has got normal IRP and normal IRP. What will you do?
So in that case, I have excluded the neuromuscular problem in terms of a dysphagia. But as the upper GI endoscopy is normal, still I will be worried that this patient may not have dysphagia second to some intramural pathology. I would request after an IBD, after an MDT meeting, I would request an endoscopic ultrasound for this patient to find out the other cause. And also I would like to have a CT scan. At this point, I would also like to have a CT scan for this patient as well.
Okay, so you have diagnosed this patient. The ultrasound, endoscopic ultrasound doesn't give any big report. CT shows that there is a dilated esophagus, probably achalasia cardia. And do you want to do IV contrast, or what kind of CT do you want to do?
So this patient would require an oral and IV contrast.
The oral contrast, and the oral contrast says achalasia cardia. How are you going to manage this patient?
I'm surprised that this patient has normal manometric findings on eclasia, because I was expecting some increased IRP.
This is fine. If at all, if this patient has got achalasia, how are you going to manage this patient?
Yeah, so I would assess this patient based on the performance status. My management plan will be based on performance status of the patient and the general fitness of the patient. There are initially I would try to do endoscopic options, which could be an dilatation of the gastroesophageal sphincter. This is the first option that I would like to do. If it doesn't work, then I would go for a more invasive operation, but it will be based on the patient's fitness.
Okay, so this patient had a balloon of the OGJ junction, and post-operative, this patient has got a chest pain. What will you think of?
Sorry?
This patient had a balloon dilatation of the achalasia and pneumatic dilatation of the achalasia, and this patient has got chest pain post-operatively.
Okay, so any therapeutic intervention for esophageal for the eclasia associated with the 5% risk of esophageal perforation.
Your second scenario time finished. We'll go to the third scenario. You are in doing laparoscopic cholecystectomy.
Sorry. You are
in a theater doing laparoscopic cholecystectomy, and you finish the procedure. When you finish the procedure, you see bile leaking underneath the liver bed. What will you do?
So I will do a laparoscopy again. You
are still in the theater.
Yeah.
And at the end of the procedure, you see some bile underneath the liver.
So what I would do, I will further inspect this liver bed area. I will use my suction and trying to find out where this bile is coming from. If it is coming from the gallbladder bed or a duct of Lushka, I have an option that I will clip this. But if I can't find and then I will see the my cystic duct stump as well, whether it is fine or not. And my further management plan will be based upon what are my anticipation based on the intraoperative findings.
Your cystic duct is fine, it is clean, and you sucked it, you washed, and there is nothing. So what will you do now?
So then I will wait and inspect that how much the bile is coming from. If I was happy with the anatomy of the biliary tree, and I think that there is no further bile coming from, and the junction of cystic duct to CBD looks fine, then I will just place
Everything is fine. Everything is fine.
Yeah, then I will place in a drain in the liver bed, and I will come out.
Post-operatively, you have you come out, and then post-operatively you come out, and use second post-operative day, the drain says there is around 250 mils of bile.
This is a very surprising finding for me, because generally if the intraoperative findings were not suggesting for any biliary disruption, that did not allow me to operation, but it is a very surprising finding. However, I'm left with no other option rather than doing CT scan to find out the amount.
Scan, the CT shows there is a 5x5 centimeter collection at the liver bed.
For 5 centimeter collection, if the drain is still draining, I will first observe how much the output of bile per day it is. If it is very high output, then
you are monitoring the bile for 3 days, and third day the bile is 450 mils. Sorry, after 5th day.
At this point, I will be worried for any missed CBD injury, and in order to locate that, I will ask my guest. I will take an opinion from my HPB colleagues as well. The option that I have left is for diagnostic purpose. I can do an MRCP, but if the suspicion is very high, I will go for ERCP and stenting.
Okay, you do an MRCP, you do a ERCP. Okay, so the ERCP, you have done the ERCP, and the ERCP says there is a small bile leak at the level just 2 centimeters above the hepatic duct, cystic duct and common hepatic duct confluence.
Okay, so yes, so it's one of the major biliary duct injury. The options that while doing an ERCP, if my gastroenterology colleague can put in a stent across it, that would be the best option.
Stent, ERCP done, stenting is done. You have the drain in place. There is a injury. What will you do now?
So ERCP stenting, in that case, we should serve the purpose. I would explain the patient that you had a missed injury in the bile duct, although I had a suspicion while I was doing an operation, but as the operative field was clean and there was no further bile coming from, I did not do any further dissection or any operation there, because it must have been associated with the high complication rates. But post-op, you have a bile drain and it requires stenting.
10th day, the bile is still 500 mils. What will you do?
10th day is still on a 500. So my diagnosis would be either the stent is misplaced or not covering, or there is an other injury possibly in the biliary tract that we need to inspect. And in that setting, on 10th day, I would go for MRCP again to delineate the level of an injury.
Okay, you do an MRCP, and there's no change in the findings. They say the finding is similar, same.
And how much the output is?
Output is 500 mils on 10th day.
So MRCP did not locate this the level of injury, right?
MRCP says again the same scenario: 2 centimeter defect above the confluence between the cystic duct and the.
Okay. So I will again see the if this is so much, if this amount of output is coming, I will also see further finding whether there is an intrahepatic biliary dilatation or not. Then I am left with two options.
Is up. We'll go to the next scenario. So there is a 60-year-old female who is in ITU with a post-operative Hartmann's procedure. And this patient is in sepsis, was in sepsis, intraoperatively was in sepsis, was treated with antibiotics, still not extubated. The patient is intubated. So how the scenario is, this patient, the ITU consultant calls you with abdominal distension and the stoma is not looking good. What will you do?
So I will clinically assess this patient because this patient has recently had an operation and abdominal distension. I will be worried for abdominal compartment syndrome, as there was a difficulty in the extubation of this patient as well. I would ask the ICU nurses to measure the intra-abdominal pressure. I would also do the focus abdominal.
Intra-abdominal pressure is 18. And the stoma is not looking good. What are the things you'll check in the stoma?
Yeah, so the stoma is not looking, so so I will be worried for the stoma necrosis, which is the very commonest complication after making any stoma. So I would inspect the stoma, not only for, and I will try to find out to see the lumen, whatever I could see of the stoma. I would also do the abdominal examination as well, as this patient is intubated, so I cannot elect the signs of tenderness, but I would see the distension. If the drain was put in first place, I would see that as well. If the stoma is completely necrotic or has gone down, then this patient would require, of course, another operation and probably and the resiting of his stoma. If that is not the case, then this patient will be benefited after the resuscitation with the CT scan abdomen.
Okay, the stoma come in and they say that there is just a stoma is looking bad just above the fascia, not below the fascia. What will you do?
Sorry, stoma is looking just above the?
The stoma nurses come and examine the patient and they give you an opinion that the stoma looks bad just above the fascia, just below the fascia, the stoma is fine.
Okay, so just below the fascia, it means the stoma is sinking. If that is the case, then this patient needs to go to go again.
Sinking. The stoma is they do an examination of the stoma.
No, I'll prefer to do the exam.
Above the level of the fascia, the stoma looks fine. Below the level of fascia, above the level of fascia, the stoma is unhealthy. Below the level of fascia, the stoma is healthy. What will you do?
Okay, then the cause of abdominal examination is unlikely this, because if the rest of the colon looks healthy, then it's an unlikely cause. There are few options in the in the ITU setting I can do. We can do a colonoscopy in this setting just to see the mucosa, because the high chances is that this is unlikely.
The nurse and the stoma nurses did a proctoscopy or the colon. They did a scopy through this colon to the stoma, and it looked fine to the fascia.
Okay, so it's unlikely that is so. I will say, I think that the cause of abdominal distension is not this stoma, necrosis of stoma. This patient, after resuscitation and once he is stable enough to move to the CT scan, would require a CT scan to look for any other cause of this abdominal distension.
The CT is normal and it says paralytic ileus.
Okay, then I will sit tight on this patient for first couple of days. If the level of ischemia or necrosis is going more, is advancing and increasing, then this patient will require a return to theater and probably the resection of the distal part of the stoma and resiting of the stoma.
You want to ask anything to the ITU consultant during this time?
I would ask about I would ask about the post-op course of the patient, general status of the patient, and how much the patient's how is the patient ventilatory parameters, and whether the patient is requiring any inotropic supports or not. And I will review all the charts of the ITU chart.
This patient is on highest level of inotropic support. Do you think that might help? That might be the reason for the stoma?
The highest, low perfusion state can cause the ischemia, but in that case, the patient should have some some source of the sepsis, which
after 2 days after 2 days, this patient is you didn't do anything. You just sat tight on this patient. Things were fine, and now the patient started retracting stoma. What will you do?
So if the patient has started retracting his stoma, then my worry will be, of course, the patient the stoma can sink completely and can cause fecal peritonitis. My option would be to discuss with an ITU and consultant and take back to the theater.
This is retracting, and it has not completely retracted. The stoma is slightly retracted and doesn't look like it has completely withdrawn.
So my decision will be based on the number of days. If it is more than 5-6 days, then I think that and then I will prefer to sit tight on the patient. If it is an early post-op course and the stoma has considerably gone down, then option would be, of course, to take to the theater and reset the stoma.
On this patient in a retracted stoma.
Sorry?
When will you operate on a patient with a retracted stoma?
So if it is in the early course or early post-op course and the stoma has retracted all along its margins, then I will prefer to take the patient back to the theater. However, in the late post-op course, at least after a week, I think, and if there is a good stoma output, I will prefer not to take the patient to the theater.
Okay, this patient has got good stoma output, good post-operative progress, and CT is normal, and the stoma is gangrenous or change in color. I can't say gangrenous. There's a change in color with a retracted stoma. Will you operate or not?
Yes, I will operate. I will resect the distal part of the stoma and I will refashion this.
Okay, you have got a next patient. There is a 50-year-old female who comes in with swelling in the midline. She had a midline laparotomy 10 years back for a perforated DU. And how are you going to approach this patient?
So this swelling to me looks like an incisional hernia because of the prior operation. I will take the focus history of the symptoms of the patient, which includes the duration since the patient is experiencing the swelling, whether the swelling is associated with the discomfort, pain, or any signs and symptoms of constipation for bowel obstruction. Then I would also take the history of weight gain or weight loss during this period. I would take the history of previous abdominal, other medical conditions of the patient. I would also take the history of previous old forms of all surgeries that she had. I would also take the social history, especially the smoking, history of smoking. Then I would do a focus examination, which includes the general fitness and performance status of the patient. I would do the abdominal examination of the swelling, which looks like to me in hernia. I would try to feel the defect if I can feel.
As a surgeon, what are the things you will check in the hernia?
As a surgeon, I will see the size of the bulge. I would see the size of the defect and whether it's reducible or irreducible. What are the possible contents of the that hernia? What is the location of the hernia and how? What are the surrounding of that hernia? Because that will have a great implication on my repair. Then I would also see the weight. More importantly, I would see the weight of the patient, whether the patient is obese or not. More specifically, I would also like to see whether the patient had previous hernia repair or not. If that was, whether the mesh was placed or not. These are the special.
The size of the swelling is 8 centimeter, and this is a reducible hernia. And there's no other previous history of any episodes of flare-up or any signs of infection in the past. Patient says there's no discomfort as there is a swelling. This patient has come in and see you.
So with this size of hernia, as this is not a primary hernia, this is an incisional hernia. I would like to have a CT scan of her abdomen to better delineate the abdomen, the hernia anatomy. I would also worry for any possible underlying factors, which could be intra-abdominal pathology, any intra-abdominal pathology, any ascites,
You did a CT scan. CT scan shows 8 centimeter defect in the midline with combined small bowel and transverse colon as the content. Muscles, surrounding muscles are normal, nothing else.
So if this patient is fit enough for an operation, I would discuss this patient in the options of hernia repair, but simultaneously I would like to discuss this case in abdominal wall MDT as it is a complex hernia. However, if the patient is frail, then
patient in MDT, abdominal wall MDT, what will be the opinion from them?
So abdominal wall MDT, the opinion will be the hernia repair can, they must raise the one apprehension that the hernia repair can be associated with the loss of domain if this is a big size of hernia. The second option, if the patient is fit enough, then this patient would be benefited with the hernia repair, probably with or without preceding sessions of Botox injection to make the abdominal wall more relaxed.
Okay, you will go to the next scenario now. There is a 30-year-old female who's 4 months pregnant, who comes in with epigastric pain.
Okay, in a pregnant patient, epigastric pain could be because of biliary colics, or it could be a simple gastritis. I would take a focus history and clinically evaluate this patient. I would like to take the history of the symptoms, more importantly, for how long, whether it's worsening, it's going back or down, it's going back into the back or not. I would do the examination, seeing the hemodynamic state.
This patient says epigastric pain relating to back.
Okay, this patient may be having an episode of acute pancreatitis. As this patient has presented in an emergency, I will resuscitate this patient on the line of a CRIS. Then I would take the blood sample, which includes full blood count, UNEs, LFTs, amylase level, INR, coagulation profile to find out the cause. This patient will need some form of fluid resuscitation. I will put her on PPI and wait for the bloods. That's how I will go.
Okay, so the amylase is 900 and liver function test is normal.
Liver function test is normal?
Yeah.
Okay, so this patient is suffering from pancreatitis. Still, we don't know the cause. I will arrange an ultrasound liver gallbladder to find out the cause, whether the cause is not.
Patient?
Sorry?
Do you want to involve someone in this patient at this moment?
I would involve the obstetrics, obstetrics team as well, that this patient must have been followed with them. And I will tell them this patient on a fourth month of her pregnancy have got an acute pancreatitis, which has a serious complication, not only for the patient, but also for the fetus as well. But my mainstay of treatment would be medical management to begin with. I will keep in the patient in a hospital for pain management, for fluid resuscitation, and to find out the cause of the pancreatitis.
Okay, so you are the next day the patient is feeling unwell and the patient is using 5. What will you do?
If she's using 5, then this patient might be having a severe form of severe attack of a pancreatitis, could be having a severe attack of pancreatitis. At news 5, I will resuscitate her. I will manage the airway, breathing, and circulation. I will give her the fluid challenge again. Of course, this patient will need an investigation, some form of investigation. And I will discuss this patient that this might be a complicated pancreatitis. But before that, I would like to see the bloods, especially the ABG, arterial blood gas, and what is the severity score of a pancreatitis. If the suspicion is very high for the severity of that there is a severe attack of a pancreatitis, then I might discuss this patient with my HDU, ITU colleagues as well. It
was transferred to ITU on the second day. and the patient is intubated by the ITU consultant, what are the things you will talk to the relatives and the neighbors regarding this patient now?
So I will talk to the patient that the patient has suffered with an acute attack of a pancreatitis. Even in a normally fit young patient, this is a very deadly disease to begin with. Some patients develop a very severe course of the pancreatitis and is associated with significant mortality.
Patient relatives about the pregnancy.
Sorry.
What will you tell to the patient about the pregnancy?
I will tell that this patient, the pregnancy, if you save the pregnancy, it is good. But our first consideration is, of course, for the patient. This patient, even a young, healthy patient, sometimes cannot make out of the disease. But we cannot tell more about the pregnancy. How it will go. Only the days to come will decide about this, and I will counsel them that if the conditions still worsening, then we will need to get a CT scan to find out whether the patient has developed a necrosis of a pancreas or not.
Okay, so fourth day, this patient had ultrasound abdomen. It shows there is a stone in the distal CBD with a dilated CBD. What will you do?
So with this patient who has got sick with the CBD stone, I will discuss this patient with my GI colleagues for ERCP and extraction of a CBD stone, because there is enough evidence that suggests a role of early ERCP in severe acute pancreatitis, when especially the cause is gallstones.
Okay, the CBD ERCP is done, and again after 3 days of ERCP, this patient has spike in temperature, and there is a raised CRP.
Okay, then I will be worried. Then I will do an abdominal examination. More importantly, I will see the bloods. I will see the initial course of the patient. I will see the input-output charting. This patient could have two possible things: either the worsening of the pancreatitis in the form of a infected pancreatic necrosis, or if it is it's a very early course of the ERCP, it could be an ERCP-induced complication.
Now,
sorry.
Do you want to do any investigation now?
So in this patient, I will explain the risk to the family that I need to go ahead with a CT scan to find out the cause of this worsening symptom, worsening condition, and then
CT scan shows infected necrotic pancreatitis with a gas particle in the pancreas. What will you do now? So
this patient has a severe acute pancreatitis with the local and systemic complications. I will start her on antibiotics. She needs. So my preference would be meropenem, because it has a better penetration in the pancreatic parenchyma. Meropenem.
Okay. What else do you want to do?
So I would keep her managing in the ITU setting. This patient, I would also discuss this patient with my obstetric colleagues as well. And I will explain the family of the patient about the
After 3 days, this patient still worsens, spike in temperature, still general condition worsens. You repeated a CT scan. The CT scan shows there is a 5x10 centimeter collection in the body of the pancreas.
Okay, so this patient, I think this patient is condition is not settling with the use of antibiotic. This patient would need drain in the collection, and I will not only place a drain in the collection, but I will also like to take the sample for a culture and sensitivity.
Okay.
Time.
What was this?
Yeah, it was exam was looking less exam, more an interrogation, like a police examiner, a police officer is speaking to somebody who has done some robbery and is asking, why did you do that? Why didn't you do that? Where did you go? Where is your girlfriend? Where are you hiding your girlfriend? And so
Varun has a big potential to be very good. And
if that is the
if Varun is my examiner, I'll get up and I'll walk out. I'll say, please fail me. Bye.
Yeah, that was more an interrogation. It was not like an exam. Even those things which I knew, I was completely forgetting it. Like discussing with the